Morning, morning. I've got a bit of a different setup today, so yeah, I might be looking in different places than I normally do. Good morning, Rahul. Good to see you there, mate. Welcome from India. Had a few people from the States join in, which was really cool. So we're spreading across the globe. Right then, welcome back. We are moving on to the muscles of the knee. We covered it a little bit last week. Morning, Becky. Oh, Becky, I'm really sorry. I will get back to you today. I'm really sorry. You've just reminded me. Oh, bless you. Yeah, apologies. Been trying to catch up with everything, but that's no excuse. I will. I'll make sure I message you today. Morning, Tris. Morning. And David, good morning. Had a good weekend. Yeah, believe it or not, I was teaching again yesterday. Something that requires a good level of anatomy knowledge, which is ultrasound scanning. So that was really good. That was a good session. Good to put it all together and show people how it all works. So that's good. In fact, I've been saying about it for ages, probably a couple of years, about bringing in some scanning stuff into the anatomy, and I can do that actually. I'll do that next week. Yeah, because I've got some videos of me scanning a knee, so that'll be perfect. That'll be perfect. Morning, Talia. Good to see you there as well. Good morning. So let's get going then. We looked at the. Let me just pop this up. We looked at these. Looked at the compartments. Just scooch back a little bit. There we go. Get rid of that. So this is really key, I think, because I think it's a bit. It's not really that well known. We've talked about compartments in the leg. And again, we mentioned that last week. But we don't really talk about compartments in the thigh, and it makes things make a lot more sense when you learn it in this way. So, and also the kind of viability of some of the manual therapy treatments that are out there about changing some of this stuff as well. So, if we have a look at, because this is the thing, it's all very word related. So we've used terminology that patients use, and we use that terminology with patients to help them understand. But when you look at those words in a kind of scientific way, they don't make sense. So, for example, there's this big thing on a page I was reading the other day about myofascial release, and saying you can't release it, but and what we mean by releasing, I think from a kind of scientific point of view, physio kind of point of view, is when you have a release operation done where they use a scalpel and they cut through the connective tissue to like release a carpal tunnel, for example. So if that's the way that an individual thinks about what a release is, and then you're saying, oh, by pushing on the skin we create this release of the tissue, then it obviously doesn't compute. Moving the skin is nothing like taking a scalpel to the fascia. So I can see where the confusion is. However, having treated people for 20 odd years, people get a sensation of a release. That's what they feel. And it is a perception, it is a sensation, but it's not a physical changing of the tissue like in a surgical release. So I think that's where the confusion lies, really. And when you look at the structures, especially when we start to have a look at the videos, the way that these tissues are bound to, especially to the bones, in this case of the thigh, if we could manipulate tissue by just holding it for 2 minutes, that's what I learned when I first did myofascial release 20 odd years ago, then quite rightly, as some people have alluded to, if you sit on a hard chair for more than 2 minutes, is that going to then release your tissue, and stretch the tissue. It just doesn't make sense. So we have these kind of things in our mind about what we do, but then I think the anatomy teaches us something a little bit different. There is definitely a change that happens, definitely, because people feel it. We can feel it sometimes, and you see it in range of motion testing as well. Although, I'd like you to try something. I'm going off on one for the first bit of today. I'd like you to try something with your patients next time. So we do a hamstring stretch, right? And we used to mess about with this kind of stuff all the time. So you do a hamstring stretch, and then usually you would do a muscle energy technique for the hamstrings, if you're doing a PIR, post isometric relaxation technique, or you do an RI, so you'd contract the quads, so reciprocal inhibition, where you contract the opposing muscle group, or you might do a sustained hold over the hamstrings, or you might do some nerve flossing for the sciatic nerve, whatever treatment it is, because it's related to the test. So you would do a hamstring test, and then you would treat that area. What I'd like you to do is do a hamstring test, and then do an MET for, I don't know, external rotation of the shoulder, internal rotation of the shoulder, horizontal adduction. Just choose something, something else away from where you're testing, and then retest that hamstring again. 9 times out of 10, it will change the tissue. And then people will start saying, well, everything's connected. So you can't kind of win, because that argument, you can use that argument for everything. But the whole point is that it doesn't matter where you change, because if you've done a test somewhere and then you redo that test, even if you don't do any intervention, in fact, that's another one, don't do anything, and then there's no there's no chance that anything else can be involved, and then retest it again, and you will usually improve. So we get this post activation potentiation of the muscles, because we're dealing with the nervous system, and I mean, we haven't even got onto the nervous system, but the tissue itself. So all of these muscles we're learning about, all of the connective tissue we're learning about, is doesn't respond if there's no nervous system. There's no change if there's no nervous system, because it's the nervous system that controls everything. If you think about the muscles and the bones and the joints, connective tissue is the hardware of the body, and the software of the body is the things that programs it and gets it changing and reprogrammed, well, whatever you want to call it. And so I think it is more likely that we are having an effect on the software rather than the hardware. Okay, so there you go, my rant for today, if you've been following those discussions on massage boards. So here we go, femur, just here. So obviously in the lower leg we had 2 bones, so there was this interosseous membrane between the 2, with the tibia and the fibula. This time we've just got 1 bone, and the way that the body connects everything is via these septums. So there are these lines down here, hopefully you can see them on your screen. There's one there and there's one there as well. So we've got posterior intermuscular septum. We've got this one here, which is the lateral, and then this one here, which is the medial one. So there we go, just there. Okay, and then that connects, wrapping around to the connective tissue of the whole leg, and then there is a thickening of that tissue around here, and this is your IT band. So your IT band, and again we've covered this a couple of weeks ago, is not just a band down the outside of your leg, it is a thickening of the connective tissue that surrounds the whole limb. And so you get distribution of forces spread out throughout the whole limb, but more so down that lateral aspect, and that's why the body responds to that load by laying down more collagen tissue, so more fibroblast activity down that side of the leg, and then ta-da, your IT band is then formed. Okay, so everybody's going to be slightly different. You're going to have some that are a bit thicker than others, some are a bit wider than others, and it's just depends on what load you've put through that tissue, but it will react to that. So this blue zone area here, this is one of the compartments of the whole thigh, and called this the anterior compartment. So if you have a look, we've got these muscles, not really covered them yet, so I'll just briefly mention them. So we've got sartorius, we've got vastus medialis, rectus femoris, there's vastus intermedius, which again, it's kind of, forget about this muscle because it's tucked away underneath things, but look at the size of it. It's huge, massive muscle. And then this one here as well, this is huge. Now this one comes all the way around the side of your leg. This is vastus lateralis, and it connects into these septums, which then attach onto the back of the femur. So your vastus lateralis is absolutely massive. Yeah, coming all the way around there. Then we've got this medial compartment, so the inner part of your thigh. We've got the gracilis muscle just here, depending on where you do a cross section from. So this is that part of the thigh just there. So obviously if it was a bit higher, then you'd have some other adductor muscles in there as well. We've got adductor longus and then adductor magnus. Okay, and again, we'll talk about those in a bit more detail as we go through. And then at the back, this posterior compartment is your hamstring group. And we've got what we've got here. So biceps femoris, got semitendinosus, semimembranosus, and this is the other head of the biceps femoris, because biceps means two heads. Okay, so we've got a long head there and then short head just there. So you can see how everything's all grouped up. And then the cool thing is we've got these vessels that supply this medial compartment. These vessels and that nerve that supplies this compartment here, and then this nerve, and that this is predominantly, yeah, so there is some sharing, and we'll talk about that in a bit, but predominantly there is a nerve and some blood vessels that supply each compartment. Okay, so you can kind of separate it like that. So we're going to have a bit of a dive into that today. So these are the muscles of the anterior compartment. This is rectus femoris. Yeah, so we've got an attachment right up here on the pelvis, and then down here into the top part of the patella. So this is the most superficial of what we call your quadricep muscles. So quad means four, and ceps is heads. So we've got a four-headed group of muscles. Really, it's not a four-headed muscle because they're all individual, but they all have their own, wrapped in their own connective tissue, so they can glide across each other, and they're in different sections of the thigh, and depending on what bit of the thigh they're in, they're not different compartments but different kind of areas, and depending on the area gives them their name. All right, so we'll talk about that. So rectus means straight and femoris means femur. So we've got a straight muscle that comes straight down the femur, although it is a bipennate muscle. So we've got these feathered kind of look to it just there. You can see that there and there. And then towards the end here, we've got the tendon, where it attaches then into the base of the patella. And again, we covered this a little while ago when we did the bones, but the base is at the top and the apex is at the bottom because of the shape. Yeah, sometimes we call it a proximal and an inferior pole. So the proximal is closest to the body, distal is distance is furthest away. Okay, so that's your rectus femoris. Let's have a look at some of these videos. Get rid of that one. Hopefully this will be it. So rectus femoris then, let's have a look at that. So touching up in the pelvis, and then coming down to the knee. So it crosses two joints, this one. So let me just pause that there. So up here on the pelvis, we haven't covered the pelvic bony anatomy yet, so this might be a new name for you, but it's there's lots of abbreviations around this area, and this one is called the AIIS. So the A means anterior, the first I is inferior, the second I is iliac, and then the last S is spine. Okay, so anterior, inferior, iliac, spine. So the iliac spine is like the the top part of the pelvis. Yeah, so that from front to back, that's the iliac spine. So at the front is called the anterior iliac spine, and at the back is the posterior. And then we've got these bony lumps that are higher or lower. So we've got some superior lumps and some inferior lumps. And this particular muscle is connected to the inferior lump at the front of the iliac spine. So anterior, front, inferior, below, iliac spine. Right, so up here on the pelvis, you'll be able to see in a sec. It then the distal attachment is the tibial tuberosity, so on the front of the tibia, which we looked at when we looked at the knee bony anatomy, via the patella tendon. So all of these muscles, these quadricep muscles, they all join together, converge into one tendon, and then envelop the patella and then drop down onto the tibial tuberosity. Okay, so let's have a look at this then. So there's your pelvis at the top. This is vastus lateralis here. Okay, usually with dissections, they are old people. They're in their 80s, usually 90s. So some of the musculature looks quite small. On a younger person, a more athletic person, these muscles would be a lot bigger. So that's why they look a bit smaller. So there's vastus lateralis. There's your rectus femoris there. And interestingly, it's got two heads, which not a lot of people know about. And it's got a slip of tendon tissue on the supraacetabular groove. And again, we've not really talked about the pelvis yet, but we're gonna excuse me, that was brewing for a while. It's just on top of the socket. So the socket for the hip is called the acetabulum. So the supraacetabular is the superior part of the acetabulum at the top. So we've got a slip of that rectus femoris that comes out and attaches up there as well. And then the other head of it attaches onto the AIIS, so that anterior inferior iliac spine. Now, you can feel a different kind of stretch on your rectus femoris. So you know when you do a quad stretch, when you bring your heel to your bottom, if you do that and then rotate the leg so that you're moving the femur internally and externally, so you basically bring your heel up to your bottom is what you normally do, but then if you rotate your femur so your foot is more on the outside and then rotate it so it's more on the inside, you'll feel the stretch on that muscle in different places, and it's because of the attachment points. So you'll slacken one attachment point and lengthen the other one, and then you'll slacken the other one and lengthen the other one when you go the other way. Okay, so have a play around with that and do it on yourself and just see what it feels like. But if you move your leg in different directions whilst you've got a stretch on this rectus femoris, then you'll feel it in different places around the hip. And sometimes people feel like hip discomfort around here, and we think it's maybe the glutes, but it could be rectus femoris. So look at it there, it's just above the hip. Yeah, and then AIIS just there. So those are your attachments around the hip, and then down in the knee, so this is your rectus femoris in the middle, there's the quadriceps tendon. So we've got a couple of muscles that we haven't really covered yet, but they've come onto the scene already. So this is vastus medialis. Sometimes it's abbreviated as VMO. You think, well, what's the O? Well, vastus medialis oblique. And it's because these fibers run in an oblique direction and then attach into the patella. Okay, vastus lateralis is this one on the outside, and then rectus femoris in the middle there. Okay, so this is your patella just under here, but again, it's all wrapped in tendon connective tissue, so you can't see it very well until it's all dissected out. So yeah, vastus medialis here, and then rectus femoris there. So they all, you can see how they all kind of converge together. So that is that one. And the this one is a common one to get injured because it crosses two joints. Yeah, so we've got this part of the rectus femoris is going to cross the knee. This part of the rectus femoris crosses the hip. So it will be involved in, if we have a look at the actions of the muscle, it will be involved in hip flexion, although it's quite a weak hip flexor, but it will also be involved in extending the knee. So hip flexion and extension of the knee, and it obviously can do that at the same time. So any muscle that crosses two joints, so is biarticular, are more likely to get injured. Okay, so just bear that in mind if you see anybody with injuries. It's usually the rectus femoris. If you see, again, it's usually goalkeepers in football. If it, although it can happen to anyone, but because they have to kick the ball quite far whenever they do, but for most of the game, if they've got a good defence, they're not really doing very much. But then the ball comes to them, and then they give it a good old boot. That can injure that muscle. Okay, so doing that kind of action, that kind of force, can injure that muscle, and that's quite common. I have had a patient who ruptured both of his quad tendons by sprinting, okay, at the same time, which is very unusual. Okay, but he had those surgically repaired. He was a quick guy as well. He was a footballer, used to play on the wing, and ruptured both quadriceps tendons. So yeah, sprinting, any kind of powerful kind of activity, really. Cool. So that's your rectus femoris. This is vastus lateralis, and this is the one that I was saying that is absolutely huge. So it wraps from the front of your thigh all the way around to the back and attaches into the back of the femur via that septum. Okay, so and there's a line down the back of your femur, which we mentioned when we're doing the bony landmarks. It's called the linea aspera. So the white line basically, and that is where your vastus lateralis will attach. Yeah, here we go. So intertrochanteric line. So this is up here. You've got, again, we've not really covered the hip yet, but there's two trochanters in the near the hip joint, and so the intertrochanteric line is in between those two trochanters. So that's what that means. And then you've got greater trochanter, gluteal tuberosity. So there's a raised area where the glutes attach, and again we'll talk about that when we get to the hip. And then the lateral lip of the linea aspera, which is what we've seen. So that's that white line. It's like a raised ridge on the back of the femur, and the septum will attach into there, and the vastus lateralis will attach into that. Okay, so it wraps all the way around the side. So yeah, usually when you are doing treatment for the IT band, the IT band's a few millimeters thick. This is probably contributing to that person's symptoms if they have symptoms on the lateral aspect of their leg. Okay, so again, above and below, absolutely, where the IT band starts and finishes, maybe playing a role in the stress on that tissue. But don't forget the vastus lateralis underneath, yeah, because that's what makes up the side of the leg, is all that muscle just there. Right, let's have a look at that one. So vastus lateral. Oh, we've got both together. Okay, cool. So let me show you the other one as well, and then we'll do those both together. So you've got vastus lateralis, vastus medialis. So these both, so you got one on the outside, one on the inside, and these both kind of come round to meet rectus femoris in the middle. So vastus medialis is the VMO. So that was the oblique part of it. So this is the inside of the knee. There's your rectus femoris. This is your vastus medialis. So again, really big muscle. But what you'll notice with both lateralis and medialis, they don't cross the hip. So they have no role to play in hip movements, so no hip flexion, but they are very powerful knee extenders. Okay, and that's their role. So let's have a look at those two together. Get rid of that and that one. Here we go. So this is both vastus lateralis and medialis together. Okay, so those are your two muscles. Let's just pause that there. Just give you a bit of an orientation of everything. So I'll pause at a certain point so you can take screenshots if you need to for revision purposes. You've got all of the information that you'd need there for an exam. So origins, insertions or attachment points, their actions, the nerve, and then the arterial supply as well for that particular muscle. So vastus means vast. So, or depends where you come from, vast. Okay, so Queen's English, it's vast. So it's big. It's a big old muscle. Yeah. So vastus medialis is big, vast, and it's on the medial side. Vastus lateralis is vast, and it's on the lateral side. The other one that we had a look at before we saw that on the compartments was vastus intermedius. It's vast, and it's in between the two. Okay, so that's why they're given their names, and they all do the same job. They're just in different parts of the thigh. So these are the oblique fibers of your vastus medialis. Just come down here, and then there's the vastus lateralis. And like I said, these are quite small muscles because the donors are usually in their 80s. So you think, well, blimey, I'll be able to get my hands all the way around that thigh. But obviously on a person who's athletic, these muscles would be a lot bigger. So this is a huge muscle, attaches on the posterior part of the femur, so that linea aspera. But you can see how they come together. But look at it, it's all the way around here. Absolutely huge. So sometimes you can get confused by having a vastus lateralis injury and thinking it's a hamstring one, because it comes all the way around the back, and you might feel it in the back of your thigh, whereas actually it's vastus lateralis rather than your biceps femoris. So there's the attachments there, look. So they come all the way around, nearly covering the whole of the leg. So that's the attachment for vastus lateralis, huge, all the way up there. There's the intertrochanteric line, all the way down there. There's the linea aspera, and then there's medialis attachment there. Okay, another huge attachment point on the other side of linea aspera. So they're both coming round from the front to the back and then attaching quite close to each other, but via the septums that attach into that area. Cool. Nearly there. Vastus intermedius. So this is in between the two. Again, a knee extender, that's all it does, because it attaches on the femur and then down into the patellar tendon down here. And we had to look at the tendon last week, I think it was. So yeah, anterior part of the thigh again, but this is in between the two. So in between your vastus lateralis and the medialis. Let me just check. I don't think we've got a video for that one. No, there's no video for that one, I'm afraid. So yeah, you're just gonna have to use your imagination or Google it. Okay, so we've got this vastus intermedius between the two. All of them do the same job, extending the knee. They all attach on the thigh, on the femur. Some of them medially, some of them laterally, some of them in the middle, and then they all come together down to the patella and then attach onto tibial tuberosity. Now, this one, I've dissected a few knees, and I've never found this muscle, but it must exist. Well, I have seen pictures of it, but I've never been able to find it. It's articularis genus. It's a really small muscle that sits underneath your vastus intermedius, and it attaches onto the suprapatellar bursa. We talked about that last week, and we looked at the capsule of the knee and all the different bursa. So when you flex and extend your knee, this little muscle will pull the suprapatellar bursa superiorly. So because the pouch that is the capsule and the suprapatellar bursa, if you don't have something that can pull it up as you move the knee, then parts of the pouch may get caught as you're trying to extend the leg. So as it comes up, that little muscle will pull the bursa out of the way, so then it doesn't pinch. Okay, how they've found this muscle is amazing, really. But that's its only role is to do that. All right, so it's got it's part of the synovial membrane and joint capsule, which we looked at last week, and attaches on the front part of the femur. So only a very small muscle, but yet it literally just pulls that bursa or that part of the capsule superiorly, so it doesn't get caught when you move your leg. How cool is that? There's a muscle for everything. Last couple. So we've got these two again in the anterior compartment. Well, this one in the anterior compartment, one in the medial, but we're going to cover them both together. So this one is the sartorius, and it is named after the tailors. So tailors, when they used to work, I don't know, back in the 17th, 18th century, they would cross their legs and work all day, tailoring things and making shoes or whatever. And because of the position they were in for that long period of time, they had overdeveloped these muscles. Okay, and you'll see them in usually in footballers as well. Their sartorius is quite well developed because of the action. So we've got flexion and medial rotation of the knee, flexion, abduction, and lateral rotation of the hip. So it's like sitting in a cross-legged position. Okay, so if you're constantly in that position, then your body will adapt and it will make this muscle bigger to cope with the load. And that's what happens with this one, and that's why it's called sartorius, from sartorial. So this is your Taylor's muscle, and if you have a look up here, it attaches really close to where the rectus femoris was. So if you remember, rectus femoris was AIIS, anterior inferior iliac spine. This one, AIIS, anterior oh, that's wrong. That should be ASIS. Should be anterior superior iliac spine. So that attaches a little bit higher. Ah, that's annoying. And then we've got the insertion on this funny old word called the pezanserine. So it's down here. This muscle joins with three other muscles, and we covered this when we looked at around the bony landmarks of the knee. And there are three muscles that attach onto this point along with sartorius. Gracilis and semitendinosus all attach onto this point. And those three muscles where they attach and then the connective tissue in between, it looks like a goose's foot. Okay, so that goose's foot is pezanserine. That's what that means. Okay, so again, we've got terminology from Jobs years ago, and that's why that is given that name. And then this looks like a goose's foot, so that's why that's given that name. Okay, so that's your sartorius. Just going to quickly skip through to gracilis, and we'll do these two together because they where they attach together. So this is the medial compartment now, so the inside compartment. And now, if you all the other ones have attached either onto the iliac crest or onto the femur. This one now, in this medial area, is attaching into your pubic region. So if you have a look here, we've got the body of the pubis and the inferior ramus of the pubis. A ramus is a branch. So we've got the main body of the pubis, and then we've got branches coming off. And we've got superior branches and inferior branches. So this one, and when we look at the pelvis, we'll go into that in a bit more detail. This one here, this is the inferior branch of the pubic bone. Okay, so it runs down here and attaches into near where the ischial area is, so your sit bones. And then it comes all the way down the inside of your thigh and then into that pezanserine area. So this is the second muscle of your goose's foot. All right, so we had sartorius and then gracilis. So let's have a look at this one. We've got both of these together. Is this one. Okay, so there's a lot going on in this. Right, so let's have a look. Can you see that muscle coming across there? Yeah. So the sartorius is the superficial muscle, and again, like I say, in people who play sports, and especially sports where you change direction a lot, you can usually see this muscle really well developed. So the sartorius is in the anterior compartment, and the gracilis, which we just looked at, is in the medial compartment. Yeah, so we've got crossover of compartments here, but they both attach into the same place. Yeah, in the leg down the bottom. So let's have a look at these. So there's your vastus medialis. This is the sartorius down here. So that's it there in the trail guide book. That's what it looks like. There's your gracilis in the trail guide book, and that's it there. Okay, you can see that coming down. They're both attaching on that same point. So we've got what's called the Sargent group, SGT. There we go. So sartorius, gracilis, and semitendinosus, and that's where they're attaching into there. Let me just pause that a second. So here is the inside of your tibia, that bit just there. This is the medial condyle of your femur. That's the tibial tuberosity just at the front. So when you're looking at assessing this area, there's a lot going on around here. There's 3 muscles that attach into there, but there's also the medial collateral ligament, the medial meniscus around that area, so in between the joint space. And if you remember me saying last time when we looked at the meniscus, the medial collateral ligament finishes around about there, so it goes really far down. And if you've got any swelling coming out of the knee just here, it can trickle down underneath the MCL, the medial collateral ligament, and down around this area. So quite often we'll go, oh, the pes anserine is a bit tender, so maybe we need to do some treatment for sartorius, gracilis, or semitendinosus, need to check them. But it may be the fluid coming from the knee coming down and irritating these structures down here, and we won't know unless, well, if you don't have any imaging, you'll give your treatment a go, and if it's not working, we'll go, do you know what, you need to go and get checked out because it's not responding to what I thought. And if there's something wrong inside the knee, doesn't matter what you do to those muscles, it's not going to help those symptoms. Okay, so there's a fair bit going on around this area here, so there can be a multitude of issues causing sensitivity. So yeah, you've got the 3 attachment points there. So that's your goose's foot, that pes anserine area, and that was it. Just go through that again. So sartorius, that one, so that's anterior compartment. There's your vastus medialis. There's the gracilis, just there. Okay, and then 1, 2, and then eventually you'll get a 3rd one. There it is. So those are your 3 attachment points. That's your goose's foot on the inside of that tibia. Okay, it's just medial to the tibial tuberosity. Right, what time are we? Perfect. I think that's not a bad time to finish. So next week we will go on to, we'll start with the medial compartment. So we've had a look at the anterior compartment. We'll go on to this medial one and have a look at the adductor muscles, go over gracilis again, and then we'll do the posterior compartment as well. And if we get time next week, then we can start on the nerve and the blood supply. So we're starting to get to interesting area with the nerve supply, especially because we've got 3 nerves coming down into that area of the thigh, controlling the different compartments. So we'll have a look at those. Brilliant. Let's just make sure I've not missed any questions. All good. Perfect. Right, I will see you next Monday, 10 o'clock. See you then.